I'm David Brown. I'm a urologist, and I've been in practice for 22 years this summer, and but I've been here at Knox for 11 and a half years. And Dr. Henry is one of my partners. He and I have been partners for 15 years, and this summer we're getting a third partner. Let's see. Here we go. So myself, Dr. Henry, and then next month we'll get Daniel Evans. So we'll have 3 doctors up here at Knox, but we also have 3 physician assistants. And our physician assistants are excellent providers. They're smart, they're caring, they're kind. They know how to do the necessary evaluation and management for BPH and also for urinary incontinence. The only thing they can't do is surgery. But they can do pretty much everything else that we do, and they do it very well. So they're an excellent asset to our team here at Premier Urology at Knox Community Hospital. And I've been asked this question a million times, but people say, "Doc, why'd you choose urology? You know, it seems like kind of a silly specialty." And so I make them put a nickel in a jar, and you should see how many nickels I got. A ton of nickels. You know, I didn't choose urology specifically for what I do, but I chose it because I get to see men and women, I get to see old people, young people, and we treat a whole different host of diseases. And I get to do surgery, but I also get to help people without surgery. So there's a nice variety in all of that. And my day up here, like today at Knox, I got here. I did 5 surgeries this morning, and I went over to the office and saw a whole bunch of patients, and both regular patients, and I did some procedures, and it was a nice day. And now I'm here getting to talk to you all. And so today we're going to talk about voiding dysfunction. They asked me, "What do you want to talk about?" And I said, "Well, how about voiding dysfunction?" But that covers so many different diseases and symptoms, but anything from urinary retention, where you can't pee at all, and believe it or not, it doesn't just happen to men, it can happen to men and women, and then urinary incontinence, where you're wetting yourself, and that can happen to men and women. We're going to start with BPH, and on the right hand side you'll see kind of a picture of the bladder and urine exiting bladder, and it has to exit through the prostate before it gets to the urethra and then to the toilet, or out behind the barn or the tree or something like that. And then on this side you see BPH, and BPH stands for benign prostatic hyperplasia, which is basically benign growth of the prostate. Not cancerous growth, but benign growth. And the prostate is surrounded by a shell, and that shell kind of contains the prostate. So when it grows, it doesn't grow out, it grows in. When it grows in, it pinches or squeezes on the urethra, and this is supposed to show kind of it squeezing on the urethra. So if the prostate's squeezing on the urethra, over time, the man will develop symptoms. They might notice that, you know, they feel the urge to go, but when they go into the bathroom, it doesn't come out right away. Maybe they have to stand there for a little bit before it starts coming out. And their flow, when they think back to their younger years and they could pee over fences or write their name in the snow, now it's just a trickle, and gravity is kind of pulling it out versus having a forceful stroke. And sometimes they may even have to strain in order to try to get the urine through this restricted area. And those are kind of what we call more of the obstructive symptoms. But there are other symptoms of BPH, urgency and frequency, and oftentimes the frequency is because they're not emptying out their bladders very efficiently. So if you take a full bladder and then you're only going this much, well, it doesn't take very long before it fills up again and you feel like you got to go, so you find yourself going more frequently. So when a patient comes to our office to have an evaluation for BPH, this is one of the first things that we give them. And anybody in this audience who has seen me before, you've probably filled this out multiple times whenever you come to the office. And it basically is a way for a urologist to evaluate the severity of a patient's symptoms and also how much is it bothering them. And size doesn't necessarily correlate with the severity of the symptoms. I can tell you that right away. And so incomplete emptying, I've already touched on that, where you're just taking a little bit off the top and you're not emptying the bladder very efficiently at all. Frequency, we mentioned that. Intermittency is another symptom. So man starts to pee, then it stops, then it starts, then it stops, and then it starts, and then it stops. And so they're there for a longer period of time until eventually they get enough relief of what they got out of their bladder. Urgency. Urgency is that sudden urge to go. And with BPH, we don't see urgency right away or early. We usually see it later on in the disease. And oftentimes it's a secondary symptom of having BPH for a prolonged period of time. Urgency can also be a symptom of an overactive bladder. And so as a urologist, we have to be careful to say, is this urgency from the prostate, or is it from the bladder, or both? Sometimes it can be hard to tell. The slow stream, the weak stream, we talked about that. And the straining, we talked about that. And then getting up at night. Believe it or not, getting up tonight to pee once or twice a night is actually normal. And I know there's a lot of men who, they come to see me and they're like, I've slept through the night my whole life and now I'm getting up once a night. And I say to them, that's pretty normal. And the reason it's normal is, how often do you go 8 hours during the day without peeing? Not very often. So why should you go 8 hours at nighttime? If you're drinking enough water and you're adequately hydrated, you should have to wake up once, maybe even twice at night. So we really only consider the nighttime a problem if it's 3 or more every night. So we have our patients fill out this score, we add it up, and then you can see here 1 to 7 is mild symptoms, 8 to 19 is moderate, and 20 to 35 is severe. And this symptom score has been around for my entire career, and I know it was well before then. So we're talking 30, 40, 50 years that urologists have been using this score. So oftentimes when a patient comes to see me, we talk about their prostates and their prostates and their prostates. And that's really important, but what's also important is how much is this big benign BPH prostate affecting the bladder? And what I mean by that is if the bladder has to work harder and harder and harder and harder to get that urine out, and the obstruction is not treated medically or surgically for years and years and years, well then it really makes a toll on the bladder and can actually start to harm the bladder. And this shows you kind of the progression of the disease. A healthy bladder is smooth. If I look in there with a telescope and the wall of the bladder is nice and smooth, then that's a healthy looking bladder and it's not having to work too hard. But as the bladder has to work harder and harder, the muscle fibers start to thicken. And that's, if you were to lift weights, the more weights you lift, this muscle gets bigger. So in the bladder, the harder the bladder has to work, the muscle fibers get bigger. And then you see that the muscle fibers are getting even bigger here. And when it gets to this stage, patients can have a real difficult time emptying their bladders. And oftentimes we see when it gets to this stage that the bladders just one day wake up and they say, I'm too tired, I'm going to stop working. And then the man can't pee at all. And oftentimes they have to go to the ER, get a catheter, and then they come see me a day or two after that. And so, as a urologist, we focus on, the symptoms and how much they bother them, but also we want to prevent the progression of the disease so that the patients don't end up having to wear a catheter long term, because nobody wants to do that. You can imagine that, right? So how do we treat medications? Like I said, observation is an option. If the symptoms aren't really bothering the patient and they're not having any physiologic consequences of their enlarged prostate, infections, blood, stones, retention, then we can observe it, okay? But if we do treat it and the patient says, this is bothering me, and I'm to the point where I would consider trying a medicine to see if it works, then we usually often start, the first line, we usually start with the alpha blockers first. That's kind of the mainstay initial treatment. And most people have heard of Flomax. It's a really common medicine that's out there. However, in this day and age, you hardly see any branded drugs anymore. It seems like everything's generic, and the insurance companies are obviously really pushing that. And so Flomax is actually called tamsulosin. And then another one, maybe not as well known, is uroxetrol, and the generic is alfuzosin. And then there's another one called Rapaflo, pretty cool name, Rapaflo, or Flomax, right? That's silodosin. And then the way the alpha blockers work is they relax the muscles around the prostate and can help the urine pass easier through the prostate and outside. And so they relieve some of the restriction by relaxing the muscles around the prostate. And then another medication class is called 5-alpha reductase inhibitors. And the oldest drug in this class is Proscar. People may have heard of that. But the more common name is now finasteride, which is the generic name. And these drugs work by trying to shrink the prostate. So if you can shrink the prostate, then it may open up the channel and may help the urine to pass easier out of the bladder. And what I like to tell patients is the medications are great and they do work, but it's not going to shrink your prostate from this size down to this size. It only shrinks it by about 20%. But in some men, that 20% is enough where it gives them relief. The right half of the graph is more of the minimally invasive procedures. Resume is, it sometimes can be done in the office, sometimes not, but it's kind of like a steam or hot vapor that tries to ablate the prostate tissue. Urolift is these clips or these implants that try to open up the prostate. Any prostate procedure, any of it, tries to relieve the obstruction caused by the prostate. So don't forget, the obstruction is prostate can't grow out, it grows in. When it grows in, it pinches on the urethra. So if we could open up the channel that goes through the prostate, then it makes it easier for the urine to pass through there. So any procedure tries to open up that channel. You can open up the channel by ablating it or resecting it or physically spreading apart the channel to open up the channel. And Resume does the water vapor, like I was saying, and Urolift, it physically spreads apart the urethra. And then there's aqua ablation, which this device that goes in the urethra and it uses water pressure and heat to try to ablate the tissue. The oldest procedure is called the TURP, which stands for transurethral resection of the prostate. Layman's terms is a roto-rooter, but it's been around forever and ever. Where basically the urologist looks inside the prostate channel and scrapes out the prostate tissue, trying to open up the channel. If you open up the channel, the urine passes easier. And then the HOLEP, which stands for holmium laser enucleation of the prostate. And that's for the really, really big prostates. And I've seen 3 this week. What I mean by really big is when we estimate the size of the prostate. So, average size prostate is probably anywhere between 40 to 50 grams. That's usually an average size. But then once you get, 50 to 120, 150, that's a big prostate. And then huge prostate is anything over 150. And I've seen 3 of those this week, amazingly. And the HOLEP, basically what the urologist does is takes a laser and tries to literally core out the prostate channel, kind of like coring out an apple. And basically you take a channel that looks like this and in the end looks like that. So then obviously those men have an easier time peeing without the obstruction. And then, so I touched on Urolift. It is a procedure that Dr. Henry and I brought here to Knox just this year, this calendar year we did. It's a really nice procedure because it's considered minimally invasive, very few side effects, and has a fast recovery. There's no sexual side effects, which a lot of the other prostate surgeries can't say that. And what I like to tell patients is there's very little downside to this procedure and tremendous upside. So basically, I look inside the prostate channel with a telescope, and there's two lobes to the prostate, and it doesn't grow out, it grows in. And with the UroLift, we put clips or implants on either lobe, on either side, and it spreads apart the urethra. You can see on the far right, the urethra is being squeezed, tightened, and then after putting in these clips, you physically spread apart the urethra. And so patients get a lot of relief. And it's not for everybody. It's not for the big prostates or the really big prostates. It's for what we call the moderate-sized prostates. But in the properly selected patients, outcomes have been really good, and patients have been really happy with this procedure. All right, so let's transition to urinary incontinence. And there's different kinds of urinary incontinence. There's stress incontinence, which is leaking urine with coughing, sneezing, laughing. And that's commonly seen in women, particularly after childbirth. Men can get stress incontinence, but it's usually after their prostates are removed for prostate cancer. So men can get stress urinary incontinence. There's urge urinary incontinence, which is the patient has the urge to go, but just can't get to the bathroom fast enough, and they're wetting on their way to the bathroom. There's mixed urinary incontinence, which you can have both stress and urge incontinence. There's overflow incontinence, where the patient has a full bladder and it's like water over a dam just leaking out. It's overflow. And the way we assess that in the office, anybody who's been to the office, is we rub a little scanner over the bladder to see how much urine a patient leaves behind after they pee. And we can assess to what severity they're able to empty the bladder or what they're not emptying their bladder. But let's talk about overactive bladder. It's a very common thing that we see in the office. And the more common symptoms of overactive bladder are urgency, frequency, and what we call nocturia, or peeing at night. And don't forget that the peeing at night thing is the hardest thing to really evaluate, but urgency, frequency, and the getting up at night. And you can have overactive bladder with or without urge incontinence. Not every patient with overactive bladder has urge incontinence, but oftentimes many of them do. And patients have this, and they get referred to us, and after we make the diagnosis, we offer the first line therapy is behavioral modification, and what we mean by that is maybe limiting the amount of fluids that you drink after dinner. That might help decrease the number of times getting up at night. Decreasing what we call dietary irritants, which are alcohol, nicotine, caffeine. And so those sometimes help. And then there's pelvic floor therapy, which most people have heard of Kegel exercises, right? Kegel exercises sometimes can help patients to decrease their symptoms of an overactive bladder. And then if those things aren't cutting the mustard and the patient wants more relief, then we can offer them medications. And there's two different types of medications, both with the same intent. And that intent is decreasing urgency, frequency, and the leakage that comes with urgency. And the oldest class of those drugs are what we call the anticholinergics. And some popular drugs that have been around for years and years, the brand names were Ditropan or Detrol. Those were around forever. But like I said, we don't talk about brand names very much. We talk about generics. And so oxybutynin or tolterodine, those are some of the more common anticholinergics. So these drugs have been around for 30, 40 years. And they work. They do. They work very well. However, the anticholinergics oftentimes have side effects. And sometimes the side effects are worse than the actual disease itself. So the patient stops taking the medication. And the more common side effects with the anticholinergics are a dry mouth, like really dry mouth, trouble swallowing food because their mouth is so dry. Or their mouth is so dry they end up having to drink 3 times as much water as they normally do, so now they're going more frequently. So they're like a dog chasing its tail. Constipation, which can be not very pleasant. Dry eyes, is another thing that patients complain of. So, but not everybody who takes the anticholinergics have those side effects. But those are some of the more common ones. There's a newer class of drugs called the beta agonists. And the nice thing about those beta agonists is they